Hi everyone, welcome to this radiology review series. I'm Luvasi, and in this video we're going to review key imaging concepts using a question and answer format with picture OSCE style questions. So let's get started. Station 1, we've got these questions. Describe the image. What is your diagnosis? Describe how to differentiate between a tension pneumothorax and a simple pneumothorax. So you're going to notice that I'm going to be stressing so much on describing the image because I think we need to be able to describe to the radiologists what we see using their language. So here comes the answer. The image shows a PHS X-ray that is not rotated with a good penetration and inspiration. So basically I'm following this type of format right here, where I comment on the rotation, the inspiration, projection, and exposure. And then after that, I go ahead and comment on the pathology that's present. So the left hemithorax appears radiolucent with a medial deviation of the pleural edge and absent lung markings peripherally. So the left hemithorax appears radiolucent, meaning it appears darker. So I'm sure you can see that this part of the chest appears much darker than this side, with a medial deviation of the pleural edge. So we've got the pleural edge right here. It has been deviated medially. And then peripherally to this, we've got absent lung markings, which is supposed to be something like this. But then they're absent. So this is clearly a collapsed lung. So meaning the diagnosis is a left-sided tension pneumothorax. And then question 3, describe how to differentiate between a simple pneumothorax and a tension pneumothorax. So basically, a tension pneumothorax is characterized by a contralateral trachea deviation, whereas a simple pneumothorax isn't. We're saying this is a tension pneumothorax because the trachea has been deviated to the contralateral side. This is where the lung collapse is, and then upon collapse there is an increase in pressure here, and then it's causing tension to the contralateral side. So that's why this is a tension pneumothorax. Station 2, describe the image. What is your diagnosis? What alternative investigations can be safely done in pregnancy to make the same diagnosis? So this is a CTPA. The image shows a CT pulmonary angiogram, which demonstrates a contrast filling defect within a contrast opacified left main pulmonary artery. So what I'm saying here is the image shows a contrast filling defect, which is right here. So normally the contrast is supposed to fill the entire lumen of both the left and right main pulmonary arteries, as is in this case right here. But then because there is a blockage here, the contrast is unable to fill the left main pulmonary artery. So there is a contrast filling defect, and that is what we were describing here. CTPA demonstrating a contrast filling defect within a contrast opacified left main pulmonary artery. Number 2, what is your diagnosis? So definitely this is a left main pulmonary embolism. And then alternative investigations which can be safely done in pregnancy to make the diagnosis. So remember, in pregnancy we're just trying to avoid radiation. So you can do an echo. You can also do D-dimers. D-dimers are basically indicators of coagulation. So when they're elevated, they're basically telling us that there was some coagulation going on. And then you can also do an ECG, which can show you this particular pattern right here, which is S1Q3T3. S waves in lead 1, Q waves in lead 3, and T wave inversion in lead 3. So if you see this particular pattern, it just might as well be a pulmonary embolism. So basically we use the Wells criteria to assess the probability of the PE. So whenever we have a high probability, we order a CTPA in order to confirm the diagnosis. Station 3 says, describe the image, what is your diagnosis, describe the CT picture that would be seen in an acute setting of this pathology, and explain why. We'll start with the description. So this is how I described it. The image shows a contrast enhanced CT of the abdomen, demonstrating extensive hypoenhancement of the mid and distal portions of the pancreas. So for starters, we're suspecting pancreatitis because of this chronic alcohol abuse. And then it's demonstrating extensive hypoenhancement. Hypoenhancement basically means darkening, which is seen right here. This side is nicely enhanced, but then this side is exhibiting extensive hypoenhancement. It's much darker than the other side. So what does this mean? This is chronic necrotizing pancreatitis because, going to question 3, in acute pancreatitis, the pancreas enhances as it has an intact perfusion with hyperemia due to inflammation. So normally, in acute pancreatitis, the inflamed portion of the pancreas is going to enhance because contrast is going to be able to fill this this inflamed area. But then when we have severe necrotizing pancreatitis, there is necrosis here. So the contrast is going to be unable to fill this particular part of the pancreas. Hence, the extensive hypoenhancement in that particular portion of the pancreas, demonstrating this pathology. So here are some clinical pros. Acute pancreatitis is diagnosed using the revised Atlanta criteria, which require at least 2 out of the 3 criteria met in order to make the diagnosis. So you've got these 3, and then you need only 2 in order to make a diagnosis of acute pancreatitis. So normally in a clinical setting, we've got both of these 2 criteria met, which is why we don't usually order imaging for a suspected case of acute pancreatitis. We only do that if the presentation is atypical, or maybe if you have the classic presentation, but then the enzymes are not adding up, which is why this particular example showed us chronic necrotizing pancreatitis, because normally for acute pancreatitis, we are able to make the diagnosis with just these 2 criteria. Station 4 says, describe the images A and B. What are your diagnoses for both? And then which MRI sequences would be most useful if an MRI was to be done instead? And what would those sequences show? Here comes the answer. So just take a closer look at both images A and B. Okay, so image A shows right-sided. So image A shows right-sided hemorrhage with surrounding vasogenic edema, mild mass effect with sulcal effacement. So what do we mean by this? Surrounding vasogenic edema is simply this this particular darkening area around, that's the vasogenic edema. And then mild mass effect with sulcal effacement. Sulcal effacement is just effacement of the sulci of the brain. So I'm sure you can see the prominent sulci here on this side where there isn't any mass effect. But then on this affected side, you can't see any sulci or gyri, indicating compression or mass effect. And also you can see that this particular ventricle has been compressed and is smaller compared to this other one on this side. So image A shows right-sided hemorrhage with surrounding vasogenic edema, mild mass effect with sulcal effacement. And then image B shows a hypodense lesion. So image B shows a hypodense lesion. Hypodense simply means that the lesion is darker compared to the surrounding brain tissue, as you can see. It's a hypodense lesion in the left MCA territory with negative mass effect as evidenced by exvasodilatation of the left lateral ventricle. So negative mass effect As you can see, the lesion is on this side, but then this is actually an old stroke. So it's a stroke that happened a very long time ago, and then as time went on, it reduced in density, and then there happened to be some extra space in this particular part of the brain, making this particular ventricle to dilate. That's what the ex vasodilatation means. Dilatation due to new space that wasn't previously there. The diagnosis for A, this is an acute hemorrhagic stroke, and then for B, this is a chronic stroke. This is a chronic stroke, and this is an acute hemorrhagic stroke. So why are we saying that this is a hemorrhagic stroke? This goes back to the principle of Hounsfield units. The Hounsfield scale simply tells us about densities of particular tissues. So the brain has a density of around 40, and then acutely clotted blood has a density of around 80 Hounsfield units. So that means that the hemorrhagic lesion is going to appear hyperdense as compared to the surrounding brain tissue, as you can see. And then for number 3, which MRI sequences would be most useful if an MRI was to be done instead, and what would these sequences show? So the MRI sequences that would be most useful for stroke detection include DWI and ADC, diffusion weighted imaging and apparent diffusion coefficient. So what these do is that DWI measures diffusion restriction. Like in the case of a stroke, there is going to be restricted diffusion because of the edema that happens during a stroke. And then the DWI is going to show hyper-intense signal in a stroke. And then for ADC, it's the opposite, because ADC measures the diffusion, the apparent diffusion. So these two are usually ordered together. You're going to have a DWI map here, and then an ADC map here. And then you're going to have the brain on both. And then you're going to see, if this is a DWI, you're going to see hyper-intense signal in this particular area. And then in the same area, on an ADC map, you're going to see hypo-intense signal. So that simply tells us that that is a stroke in there. And then you can also use FLAIR, which is fluid attenuated invasion recovery. And this would show hyper-intense signal in an affected area. But it would only do this if the stroke is more than 6 hours old. This is just what I've been talking about in the previous slides. A hemorrhagic stroke appears hyperdense because acutely clotted blood is much denser than the brain parenchyma. And then infected brain tissue decreases in density over time, approaching CSF density, and therefore odd strokes eventually have a negative mass effect. This is a very good example, because this was an odd stroke and it had this negative mass effect, as you can see here. The lesion is on this side, but then the compression appears as though it's on this side, when it's actually due to a dilatation of this east ventricle. And then remember, we say that FLAIR is negative for a stroke in the hyperacute phase. So meaning if the stroke is less than 6 hours old, this is going to be negative. But the DWI can be positive within minutes of having a stroke. So if you have DWI positive and FLAIR negative, that means that the stroke is very early, less than 6 hours old. And this is important to us because in that case, you can consider thrombolysis, because remember, thrombolysis is only an option in the acute phase. That marks the end for today. See you next time.